one of the challenges, you know, in February of 2018, we had apalutamide. You know, that was the first one available for non-metastatic CRPC. And then about, 6 months later, we had enzalutamide. So over the last year or so, we've had both of these agents available. How do you make a distinction, or how do you decide in your own practices which agent to use? That's a tough question, and maybe, Niraj, can you just maybe address that?
I think the uses in general of any agent, given there is so much similarity between the data sets so far, is driven by how easily the drug is available to our patients. I think that's a #1 criteria for all of us. How easy or how good is the copay assistance program? And that is driving, and that will continue to drive the uses of these drugs until we saw the final overall survival data. And if a drug is better than other drug from overall survival perspective, then it will drive it will become like more evidence-based. Then you can compare which one is better, which one is not. But so far, all these 3 drugs seem to be very similar in the M0 CRPC setting and seem to benefit patients. Of course, they have not been compared with each other in a randomized fashion. So I will never compare these drugs until we have those data. But so far, to me, enzalutamide, apalutamide, and darolutamide, they seem to be benefiting, delaying skeletal-related events, pain scores, and so on. And ultimately, how easy it is for my patients to get these agents, that's the #1 factor.
Tanya, do you want to make a further comment on that?
Yeah, I would say the darolutamide data do seem to indicate, compared to placebo within that trial, smaller differences in some of the toxicities that actually my patients complain about the most when they are on one of these agents, which include things like fatigue or cognitive changes. I think falls were also more similar between darolutamide and placebo compared to the differences between enzalutamide and placebo or apalutamide and placebo. And the chemical structure is a little bit different. So I completely agree, access and formularies will drive some of our prescribing practices. But if you think about what your patients call in for and when you need to dose reduce, and when you look at discontinuation rates, and all of those things give you a sense of how much bother the agent is giving your patient, I think it's possible that there will be a little better tolerability with the darolutamide. I don't know how you feel about that.
So it's interesting. Of course, I haven't had access. None of us have access to darolutamide yet outside of a research study because it's not FDA approved. But I mean, in my experience with enzalutamide and apalutamide as a urologist, I would make the point that, I mean, these are fairly straightforward drugs. They're not the oral agents for kidney cancer or some of the more toxic agents that you guys as medical oncologists use every day. So I don't think I want to make the point that urologists certainly should not be scared away by using these agents. And heaven forbid, gosh, we as urologists grew up with BCG to treat bladder cancer, and I get a lot fewer callbacks and issues from patients being treated with enzalutamide or apalutamide compared to when I was doing bladder cancer with BCG.
Certainly, the majority of patients tolerate any of these agents well, but so if we're just trying to pick apart, and I will challenge you a little bit about the simplicity of these agents, because if we're going to maintain our patients' quality of life, they're now going to be on lifelong testosterone suppression, and I think we do need to be very vigilant about counseling them on exercise and diet to stay healthy. I think we need to make sure we're watching their bone density and supporting their bones so that they don't end up with an osteoporotic fracture, which will significantly diminish their quality of life. So I think they are deceptively simple in that we don't need to monitor a lot of things day in, day out, but we need to also make sure we're taking good care of our patients for the long term.
Excellent point.
And I just have one quick point on this. Whenever anyone prescribes these agents, I think it's very important to know that these agents have significant drug interactions with many other agents. So I agree with you. We don't have to monitor for liver function test or electrolyte imbalances, or we are not dealing with neutropenias. We used to see with chemotherapy agents, or we see with chemotherapy agents, but there has to be somebody on board keeping an eye on the drug interactions. These patients are older patients. They have comorbidities. They are on drugs for lowering cholesterol. They are on drugs for hypertension or heart diseases, and all those drugs, their levels can go up and down depending upon which one of these drugs we are using. So I think it's very important to get primary care doctors involved or a pharmacist involved in your practice if you don't have access to the primary care doctors, to make sure somebody is keeping an eye on the drug interactions.